Welcome to the skeletal system. As you can see on this presentation, there are over 100 slides, which makes sense because there's over 200 bones in the body, right? But the good news is most of the bones you already know. You know that there's 24 ribs. You know that there are several finger bones and toe bones. So we'll go through this pretty quickly and cover all 206 bones in the body. So let's get started. Here are some of the learning outcomes that we're going to cover. We're going to talk about all the subdivisions of the skeleton and, as I mentioned, all bones in the body. We're even going to talk about specific parts of the bones, which we're going to call bone markings. And then once we cover all of the bone markings at the very end of the chapter, we're going to talk about some differences between the hands and feet. We're going to talk about differences between male and female skeletons. We're also going to talk about some cool things with the spine. So let's get going. Okay, as I mentioned, 206 bones in the typical human skeleton. Now everybody can be a little different depending on how bones fused. Some folks can have 205, some folks can have 207, 208, but for the most part, everybody has 206 bones. The way we're going to break this down is we are going to split this entire chapter up, or this entire lecture up, into two sections. The first section is going to be bones that exist in the axial skeleton. Now, the axial skeleton, as you can see, is a total of 80 bones, and it's just the area that's not highlighted in blue. So basically, if we were to draw a central axis line or a mid-sagittal line down the middle of the body, like that on the right image, pretty much every single bone touching that line, for the most part, is going to be considered part of the axial skeleton. So all the bones of the head, face, neck, also the rest of the spine, and even the bones that connect to the spine, such as the ribs, are going to be included in this category, axial skeleton. Every other bone that's not in that category, that's not in that red circle or that touches that red line, basically your appendages, your arms, and your legs, and the hip bones that attach to your legs, all of those are going to be considered part of the appendicular skeleton, or the appendages. So we're going to see upper and lower extremities, and when you put all that together, you get a total of 206 in the body. As we go along this presentation, we're going to introduce the bones, and then as soon as we introduce those bones, we're going to introduce some important landmarks or markings found on those bones, and they are known as bone markings. And a lot of them you've probably heard of before, even if you haven't exactly studied the human skeleton. But understanding these terms will help you locate a lot of the bones and a lot of the purposes of these areas. For you physical therapy assistant folks, a lot of muscle attachments happen on these bone markings. For you rad tech and surgical tech folks, a lot of important bony landmarks occur in these markings, where if you have to put an x-ray beam or you have to make an incision 3 millimeters to the left of this mark, this will help you know where in the world you are in the human body. And you can go on and on and on. Nurses putting in an IV or putting in a central line. You can use these kind of cheat notes, or if you will, these bone markings, to help you understand where you're at. So a few types of bone markings that we're going to introduce right now. First, we have the angle, and then, as you can see, a body. And a really good example of a bone that has both an angle and a body is the jawbone, also known as the mandible. So an angle is really anything that refers to a corner, as you can see. So the angle of the mandible is just this corner right here in red. And then the body is just the main part. So we're going to see several bones with a body, but the mandible is this kind of just flat part, basically the whole area that makes your chin area, and a lot of it holds your lower teeth in place. So as we're going along these next few slides, make sure that you can make some flashcards or at least identify these terms with their definitions. Other terms that you're going to see a lot of this chapter and in lab is going to be 1, foramen, and 2, a fossa. So look at the picture on the top part for me, and let's get our orientation right. What we're looking at is the underneath side of the jaw, or the inferior aspect of the jaw. Basically, if you were to cut somebody's head off and then look up into their head, is what we're doing here. So you're looking at the bottom of the skull. This is the top of the roof of your mouth. So we're looking under somebody. Basically, you're on the floor, somebody's standing over you, you're looking into their skull. And the reason why I want to show you this angle or this perspective is because you can see a lot of holes in the bottom of the skull. Of course, you can see this really, really large one right here. That's called a foramen, and they all have specific names. Here's another foramen here, and you can see holes all over the place. And these holes, once again, as the slides mentioned, it's going to be for blood flow and for nerves to be passing through. So everything in the body can be connected. Another example of something that you need to know is a fossa. And a fossa is just kind of a groove or depression, generally where another bone fits. Generally, sometimes we can have fossas where things just fall in or are located. It doesn't always have to be a joint, but because we're talking about bones, we're going to mainly be talking about joints, especially in the next chapter. So a great example of a fossa is this groove right here, and it's kind of hard to see in this picture, and I'll show you a better example later on. But there's this indentation, or this divot, right behind your cheekbone area, right in front of your ear hole, and that's called the mandibular fossa. And all it is, as I mentioned, it's just a groove or a depression, and it's named mandibular fossa, so that's where the mandible bone is actually going to fit in. So generally speaking, we're going to have joints. But an example of where we're not going to have joints is if you look at the bottom picture, you can see now what we're doing is we're looking into the skull from kind of a bird's eye view. So you cut the skull cap off, you cut somebody's top of the head off or their scalp off, and you're looking inside the skull with the brain removed. But what you'll see in a skull from this perspective is a lot of grooves and indentations, and that's where your brain and other parts of your central nervous system sit, and those are also called fossae, or one is fossa, plural fossae. So it doesn't always have to be a joint, but generally it's just a big groove or depression where something is sitting. Another term you need to be familiar with is a meatus, and a meatus is simply an opening or a canal inside of a bone. And a prime example of a meatus is the external auditory meatus, also known as the external acoustic meatus, and that's literally your ear hole. It's the hole that allows sound waves to travel inside of your head to get to your eardrum and your ear bones, and eventually your hearing organs, and then to your brain, which will help you understand what you're hearing. Another example of a term that you need to know is a notch. And a notch is very simple. It's just this kind of V-like depression inside of bones, and it's going to work very similar to a foramen that we just covered. Remember, a foramen is a hole where blood vessels and nerves pass through, and a notch is just not a complete hole. It's just like a partial hole. So this picture on the bottom is actually a really good illustration because it kind of shows you both structures, both examples. Here you can see these little holes right above our eye socket. Those are known as foramen because they're holes. But then just medial to that, as we go to the nose, highlighted in red, you can see this kind of little divot inside of the orbit, kind of this little V shape. It's not a complete circle or a complete hole, but it does have this little indentation to the orbit. That would be a notch. So some people are different. Some folks have a supraorbital foramen right above their eye socket, and then some people don't have a hole. It's actually just this little notch or indentation. We're also going to talk about processes, And processes are really just extensions of bones. We're going to have two different categories. We're going to have heads of bones. For example, in your upper arm bone and your upper leg bone, we have heads. They just look like these round structures. And then the rest of the bone kind of just gets long and skinny, kind of like that. That's a okay picture of a humerus. So this circular part right here, that would be the head of the humerus. And then other parts we have are condyles, and condyles, what those are bumps that usually fit into those grooves. So remember, a fossa is a groove or indentation, and the condyles typically fit into the fossa, kind of like a glove or putting a hand in a glove. Perfect match, perfect fit. So to give you an example, we have the mandibular condyle. So the mandibular condyle is this structure right here, this kind of rounded surface structure that I'm coloring in purple. And then as you can notice, it's fitting into this kind of glove-like structure right there. And that would be called the mandibular fossa that we just introduced a few slides back. So typically speaking, condyles fit into some sort of fossa. Now we're going to talk about a whole lot of other processes as this lecture goes on. And typically speaking, wherever there's a process, we're going to have muscle attachment, and specifically tendon attachment, because remember that muscles actually attach to tendons, which attach to bones. Very rare that muscles are actually on the bone itself or attaching to the bone itself. So a few examples that we'll talk about this sharp pointy thing right here, kind of below your ear hole. That's called a styloid process. You have several muscles that attach to that little structure. And then we have this big bump behind your ear. That's called the mastoid process. And one of the major muscles in your neck actually uses that as an attachment point as well. So usually when we talk about a process, we're going to have muscles. So with heads, as I mentioned, they're just the round part of a long bone. Specifically, it's going to be on only one end. We're not going to have multiple heads. And it's generally going to fit into some type of fossa or depression. Now, sometimes we will call it a fossa, and sometimes we'll get a little bit more specific and actually have a more scientific name for it. And this is one of those examples of a more scientific name. The head of the femur fits into a socket called the acetabulum. So instead of saying femur fossa, we say acetabulum. So to give you an idea of what we're looking at here, the femur bone is this big bone, long skinny bone right here, circled in purple. And then the head of the femur is right here in green. And same thing, if you can imagine with me, it's fitting in this socket right there. And that socket is called the acetabulum. And you can see it a little better as well here on the right. So we'll talk about all those other structures as well as we proceed. As I mentioned, processes are where muscles attach. So other areas where we have processes or things sticking out of somewhere, as you can see, we have things called epicondyles where muscles are going to attach. We have spines where muscles are going to attach. We have trochanters, tuberosities, tubercles, all sorts of weird T words. And we'll discover a few of those as we continue on. So in no particular order, we're going to be covering some of these structures that have muscle attachment. First, we have the epicondyles. And the epicondyles are these bumps found on the bone. And they're generally located just above a condyle, or more specifically, proximal to the condyle, so closer to the core. So what we're looking at here in the humerus bone, this is your upper arm bone, are these two structures that kind of stick out. And we have a medial epicondyle and a lateral epicondyle in this case. And the more you work the muscles, remember we talked about Wolff's Law in chapter 6, the more you work the muscles, the more you work the tendons, and everything gets stronger, and they pull on these bones. And Wolff's Law says if you use it, it's probably going to get better and stronger, right? And if you don't use it, you lose it. So the more muscular somebody is, the bigger these bumps can actually become. Another example of that going a little off track, is this bump right here called the deltoid tuberosity. This is where your big shoulder muscles, your deltoid, actually insert on. And if somebody has really, really big muscular shoulders, they're going to have a really big bump here on this part of the arm. So epicondyles can serve in that fashion. It's muscle attachment, and they can be big or small depending on the person's genetics and their fitness levels. So to differentiate an epicondyle from a condyle, remember a condyle is kind of a rounded surface that fits into the depression, the fossa. So in green, I drew a condyle, and then a red would be a fossa. So it's kind of like that hand and glove analogy once again. So epicondyles are just bumps for muscles. We also have spines throughout different parts of the body. A great example of a spine is actually in your spine. We call this the spinous process. Makes sense. And basically, if you touch your neck, or the back of your neck, or the back of your back, you'll feel these kind of bumps all throughout your spine, and that's what you're feeling. So specifically, you can't feel the entire vertebra. You can feel the spinous process right in the middle of your spine very easily. And it's going to be the same thing. It's going to be a lot of muscle attachment. Other examples of spines that we have in the body, we have a spine on our scapula where we have a lot of muscle attachment on it and also above and below it. We also have something called an ischial spine on the bones that you sit on, and we're also going to have muscle attachment there as well. So key theme, muscle attachment. Trochanters. Anytime you see these big T words, trochanter, tubercle, tuberosity, it's all kind of the same thing. We're going to have muscle attachment. It just depends on the name dictates what bone we're talking about. So when you see trochanters, the prime example is on the big, large femur bone, largest bone in the body. And to get your orientation right here, this structure is the head of the femur. And then what we have is this skinnier part, and that would be the neck. And then the trochanters are these big bumps that I'm circling in black. We actually have two. We have a greater trochanter and a lesser trochanter. The greater one being a little bigger with the arrow pointed to it, and then the lesser is a little smaller. So we're going to have a lot of muscles attaching to these two trochanters in our femur. Once again, big weird T word, it's going to be served for muscle attachment. So we have several tuberosities in the body. Big one that we want you to know is the tibial tuberosity. And to get your orientation right here is your kneecap, your patella. So if you palpate or feel your own patella, just go distal to that and you'll feel kind of a mushy area where the tendon kind of is exposed, and then just keep going distal down your leg, and what you'll feel is this really, really big bump at the start of your shin. That's your tibial tuberosity, and that's where your really, really big quad muscles all end or insert on. So it helps you kick your knee or kick a soccer ball. Big, very important bump on your tibia for muscle attachment. Once again, the more you work those muscles, the bigger this bump's going to be. For people who don't exercise that often, it's not that big of a bump. If you've ever felt a soccer player or like a kicker of some sort, this thing, it feels like a tumor on some people. It's gigantic because the muscles work so hard that your body actually has to grow more bone tissue to compensate for that. So it's really cool. Check it out on a soccer player if you know anybody. Other structures are sinuses. We're going to actually learn about 4 or 5 specific sinuses. We'll actually put names to them in a little bit. But what you need to know for now is a sinus is just a little tiny hole. It's a cavity inside of a bone. So a little different than something like a meatus, where a meatus is actually an opening or canal into a bone, leading into a bone. Sinuses are actually embedded in the bones. And their purposes are, well, they have a lot of purposes. One is to moisten and kind of lubricate inside of your skull. Anybody who's ever had a sinus infection, you know how terrible that is when you have that dry sinus or when it's inflamed and plugged up. Also, they're designed to lighten the weight of your skull. So your head doesn't weigh, 28 pounds, right? Our neck would be constantly tired and fatigued if that was the case. So we'll talk about these openings inside of the bones in just a little bit. We'll actually put names to them. Okay, one last slide of terms, and then we'll actually dive into the bones. So first you see a crest, and a crest is just a narrow ridge of bone, usually sticks out. A great example of a crest that sticks out is your iliac crest. So if you feel kind of your sides where your love handles are located, and you just kind of dig in a little bit, you'll feel the top of that hip bone, if you will. That's called your iliac crest. Also have one in your sacrum. You have something called the median sacral crest, and it's just where all of your sacral bones kind of fuse together as we age. We'll talk about that later on. A facet, some people pronounce this word as facet. That's okay, not incorrect, but more commonly you're going to hear it pronounced as facet. And this is a flat surface of a bone connecting to another flat surface of a bone to make a joint. And the prime example where you're going to see facets is in your spine. So your spine is consisting of 24 vertebrae, and they're kind of just stacked like Legos. And there's an anterior part where they join together and a posterior part where they join together. And on the posterior aspect, they are joined together by these flat surfaces called facets. And those flat surfaces allow for very cool, unique movements in your spine. Next term is called a fissure. A fissure is not quite a foramen. It's not a nice circular hole, as you can see in the definition. It's kind of like a crack or a slit. It's a very oblong looking shape most of the time, but it's going to have the same function as a foramen. We're going to have blood flow and nerve flow coming in and out of that slit or that hole. So a great example of this is the superior orbital fissure. Right next to that supraorbital foramen, or kind of close. It's in that vicinity. It's near the eye socket, right? We'll get more specific as we go on. But that's very, very important because that allows a lot of nerves to go out to your face. Very important nerves that control eye movements. Also nerves that help you feel your face, so your face isn't constantly numb. So kind of a good thing, right? Next term is a ramus. A ramus is kind of this arm-like bar of a bone. The prime example that most folks know is the ramus of the mandible, or the mandibular ramus. And basically, it's just where that angle connects all the way up to that condyle area. So it's basically the side of your face. If you're if you're a guy where you have sideburns, kind of, it's just basically jaw to ear area would be considered the ramus of the mandible. We also have a pubic ramus. When I show you what the pubis bone looks like, there are actually two parts to it. One's a little curved, and then another one's more arm or straight-like. And that straight-like part is called the ramus, or the pubic ramus. And then last but not least, we have a sulcus. We're going to introduce the word sulcus again in the nervous system chapter, but this is a different type of sulcus. It's just kind of a groove, and a good example of this is something called the sigmoid sulcus. It's actually found inside of your mastoid process, the big bump behind your ear. And the purpose of it is just to allow a vein to kind of be down in that groove and be protected to help drain blood to go back down to your heart. So as you're studying the bones, you might see some of these terms. So just make sure you are familiar with them. Okay, we are now ready to move on to the axial skeleton. Remember, the axial skeleton is basically the 80 bones kind of in the center of your body. So draw a mid-sagittal line or plane right down the center, and pretty much anything touching that or anything close to it is going to fall under this category. If it's not part of your appendage system, your appendages, it's going to be considered axial skeleton. So recall at the very beginning of the chapter, we have 206 total bones in the body, right? And 80 of them are represented here in the axial skeleton. And we're going to cover all of these. You can see that there are 28 total bones in the skull. And when we talk about skull, we're talking about the bones in your head and also the bones of your face. So combine those two together, that makes up your entire skull. We have this one weird bone that doesn't touch any other bone. It's the only bone that doesn't have another bony connection to it. It's called the hyoid bone. So this is kind of a one-man show off by itself. We'll talk about that. And then you have 26 bones that contribute to the spinal column. You have 24 vertebrae. And then you have a sacrum bone and your tailbone, which we're going to call the coccyx. So that equals 26. And then you have 24 ribs, right? 12 on each side. And then you have a breastbone, which equals 25. So hopefully, if you do the math, you can double check me. If you add this 28 plus the 1 hyoid plus 26 plus 25, we should get 80 bones. Correct me if I'm wrong. So let's move on to the next slide and actually start introducing some of these bones. We'll begin our discussion of the axial bones with the 28 bones of the skull. Let's begin with the 8 bones of the cranium. As you can see, there are a few that are paired, and all that means is we have a left and a right. So we have a left and right parietal and a left and right temporal on either side of our skull. But then all these other ones are just singular or one bone. So the frontal, occipital, SPHENOID, and ETHMOID bones we're going to be talking about in the upcoming slides. And they all surround and protect your brain. So our first bone is the frontal bone, and you can see it's highlighted in green here. It's basically your forehead area, but it also does make up the roof of your eye sockets or your orbits, as you can see in the picture. So on this slide, we're covering a specific bone marking of the frontal bone, and recall that a bone marking is just a certain landmark on the bones. So the big one we want you to know for the frontal bone is the supraorbital foramen. And depending on the person, this can be called the supraorbital foramen or it can be the supraorbital notch. It just depends. Everybody's a little different. In this situation, you can kind of look at this skull and you can see that on the right orbit that I'm drawing the arrow to, that's more of a supraorbital notch because it's more of like a V shape. And then the white square highlighting the structure on the left orbit is more like a foramen. It's actually a complete circle. So it just depends. Everybody's a little different. Once again, the main function for pretty much any foramen in the body is going to be so blood vessels and nerves can pass through. Another bone marking of the frontal bone is the frontal sinus. And you have, as you can see in the picture, you have a left and right frontal sinus. So it is highlighted by this green structure right here. And a lot of you are probably familiar with that with any type of sinus infection or sinus headache during the springtime, potentially. Remember, the point of a sinus is to lighten the weight of the skull. It's also to just help moisten the air that you breathe in all the time. And our sinuses, once again, are just tiny little holes inside of the bone. So this is inside of your frontal bone. You have very, very small little cavities called sinuses. Our next bone is the parietal bone. And if you notice on the top of the slide, the title says parietal bones because this is paired. We do have a left parietal bone and a right parietal bone. And this is basically kind of just the lateral superior aspect of your head. Our next bones are the temporal bones, same thing. These are paired. So you have a left temporal bone and a right temporal bone. And we're going to learn a lot of cool bone markings on the next few slides with these temporal bones. So the first few bone markings are the mastoid process and the external auditory meatus. We've already actually covered these two previously. The mastoid process, remember, is just the big bump behind your ear hole or posterior to your ear hole. So this structure right here with the red arrow and the star. And then the ear hole itself is the external auditory meatus, also known as the external acoustic meatus. So once again, anytime you see a process such as the mastoid process, that's going to be for muscle attachment. Very large muscle in your neck, the sternocleidomastoid muscle, actually attaches here. And then the meatus is just a canal or opening into a bone. A few more bone markings. One is the styloid process. Anytime you see the word styloid, that's going to refer to a sharp needle-like process. And you can see with the red arrow pointing to the structure, it kind of looks like a stylus or a pointer. Once again, we're going to have muscle attachment in this area as well. Next is the mandibular fossa. And recall that a fossa is this groove or indentation where a condyle usually fits. So you really can't see it that well on this picture. Ideally, to see the mandibular fossa, we turn the skull upside down or look at an inferior view, but here, highlighted in black, is where the mandibular condyle fits inside of that mandibular fossa, part of the temporal bone. And then last but not least, we have the zygomatic process, and the zygomatic process is going to connect to our zygomatic bone, as we're going to see in a little bit. So in purple, I'm going to highlight the zygomatic bone. And the process is just that green piece sticking out towards that zygomatic bone. Now, sometimes in your book or in your lab manual, you'll see the term zygomatic arch, and that's just a combination of the zygomatic process of the temporal bone and then that part that sticks out of the zygomatic bone. Believe it or not, it's called the temporal process. So it's kind of like a bridge of two countries connected, and each country owns one side of the bridge, and at the halfway point they just meet and connect. So that's the zygomatic arch. It's just a combination of those two. Next, we have the occipital bone. We only have one of these. It's just the back of your head bone that protects back of your brain. And a few important markings that we have with the occipital bone. One is the foramen magnum, a very important bone marking. Remember, foramen is a hole, and this hole is really, really big. So what we're looking at here is that ideal inferior view that I was mentioning with the mandibular fossa. So while we're at it, I can actually point to the mandibular fossa. It's just this indentation or groove right behind the ear hole, right in front of the ear hole, and right behind that zygomatic process, that zygomatic arch would be the fossa. And then if you look at the picture on the bottom, you can also see the foramen magnum as well, just a really big hole in the bottom of your skull. And this is what actually connects your brainstem to your spinal cord. So it literally connects your neck to your brain, your head area. So very important hole. And then we have the occipital condyles, and the occipital condyles are these two raised bumps right next to the foramen magnum. And what they look like are these structures right here that I'm highlighting on the top picture in purple. And they're smooth surfaces, and what's going to happen is the top bone in our neck, called C1 or the atlas bone, is going to fit snug right against those occipital condyles, and that's going to help your neck hold your entire head up. So basically it's where your head and neck meet. So if you were to break that top bone in your neck or break part of this occipital bone, a lot of times you have some serious issues, severe paralysis, even possibly death if this foramen magnum is negatively affected. Moving right along, we have the sphenoid bone next, and the sphenoid bone is a very irregular, crazy looking bone. It kind of looks like a butterfly, bat wing, bird looking thing. You can make your assumption or your analogy. So where this is located is in the very center part of the cranial floor. So if we were to look at the skull, it's kind of a small picture. I'll show you a better picture on the next slide, but if you were to look at the skull, you can see that this is the frontal area or the anterior aspect, and then this would be the posterior aspect. You can see that foramen magnum that we just covered. And the sphenoid bone is just this butterfly looking bone right here in red. So kind of somewhat in the middle of our skull. And because it's in the middle and it's connecting all the surrounding bones of our skull. It connects your frontal bone and your parietal bone and your temporal and your occipital. It's kind of what we call the keystone of the cranium, just meaning that it's just this connection point. And then you can see on the bottom that it also forms lateral walls of the cranium. You can see it in purple here on this slide. So kind of between the frontal parietal bone and the temporal bone is just this little tiny piece that sticks out of the sphenoid bone. And it also is involved with the orbits. So there are several bones that we'll talk about that actually make your orbital sockets, and the sphenoid is just one of many. Markings of the sphenoid bone, very important, are the optic foramen. The optic foramen are usually called optic canals in lab manuals and atlases. So if you see that, just know that's the same thing. And what the optic foramen or optic canals are these tiny little holes. Remember, foramen is a hole. And it allows the nerve in the back of your eyeball to be connected to your brain. So this is where your optic nerve actually travels through so you can see. If this area was occluded or closed off, or if the nerve was severed, you would be blind in that respective eye. So very important that the sphenoid bone protects this area. Another important bone marking of the sphenoid bone is right behind those optic canals or optic foramen. We kind of have this pouch, this little indentation, if you will, called the sella turcica. And what that translates as is Turkish saddle. So it's kind of like a saddle that you would throw on a horse or something. And it kind of has that indentation looking appearance to it. And the reason why it's indented is because it houses, or it holds, a very important endocrine gland called the pituitary gland. And we'll spend more time on the pituitary gland in a couple modules also next semester, but this is a very important gland that secretes a lot of your different hormones. Specifically, 8 hormones come from this one tiny little gland in the very center of your brain. So it has to be protected. It has to be kind of in its own little cave, and that's what this sella turcica is, this depression or saddle that holds this gland. One last marking for the sphenoid bone is the sphenoid sinus. And basically, if you were to cut open the sella turcica on the inside, you would have this hollow opening, and that's the sinus. And you really can't see that from the anterior view. There's too many structures in the way, such as the orbits and the nose. So really, you can only see it on the lateral view. And that structure in red, that the red arrow is pointing to, would be that. So the sella turcica is just this area right here, this kind of dip. So we would have to actually cut it in half using like a mid-sagittal cut to see inside of the sphenoid sinus. Okay, last bone of the cranium is the ethmoid bone. And similar to the sphenoid bone, this is very irregular, very odd. I mean, just take a look at the picture on the right. It looks like a sword dagger looking thing on both sides. Very unique. And the location of this is even more anterior to the sphenoid. It's basically behind your nasal bones and in front of the sphenoid bones. So a lot of it borders the frontal bone. So kind of between the frontal nasal sphenoid area. And you can see that it also is involved with the orbital socket. So it does form part of your eye socket. You can see the picture here, highlighted in purple. But it also goes down. You can see this sword-like projection going down. It's also involved with your nasal septum. Now, your nasal septum is covered, is mainly cartilage. That's what we typically think of. But there actually is bone underneath all that cartilage. And part of that bone is a certain structure in the ethmoid bone. I'll show you on an upcoming slide. But we're going to have different functions such as separating the left and right nostril. We're also going to help with smell, as you'll find out in just a second. Okay, so we're going to have 5 specific bone markings that you are responsible for with the ethmoid bone. The first one is called the cribriform plate. The cribriform plate. And what these are just 2 plates on either side of this very pointy looking thing. This pointy looking sword thing superiorly is called the crista galli. And then on either side of the cribriform plates, either side of the crista galli are these 2 plate-looking structures, and those are called the cribriform plates. And the really cool, unique thing why this is so important is the cribriform plates have several dozens and dozens of holes throughout them, and what penetrates or what goes through those holes are branches of your olfactory nerve. So olfaction means the smell. So this is the nerve that actually comes off a structure in your brain and helps you smell. So damage to this area would cause the absence or difficulty of smelling things. So it's where it actually has a passageway so your nerves can help you detect what's going on in the world around you. Similar to the frontal bone and the sphenoid bone, we do have sinuses in the ethmoid bone. We have a lot of sinuses, specifically in the ethmoid bone. You can see in this picture they are highlighted in the purple looking structures. So the number 2 are purple. And you can see a few from the anterior view. If you look at the lateral view though, kind of in that orbital socket area, a lot of sinuses within this ethmoid bone. Another important landmark or bone marking for the ethmoid bone is something called the perpendicular plate. So we said the crista galli is that superior sword-looking structure. The sword-looking structure on the inferior aspect is called the perpendicular plate. And this structure actually goes down towards or the inside of the nasal cavity, so it kind of looks like this. And this is what actually makes up the superior portion of your nasal septum, which is going to separate your left and right nostrils. So it's the upper portion or superior portion of your nasal septum. We're actually going to have a bone that makes up the inferior portion. So they're going to kind of come together to make up the entire nasal septum. And then last but not least, we have the conchae, and some people pronounce this conchae, that's fine. A lot of your textbooks, though, actually show the proper enunciation is conchae. So we have superior, middle, and inferior conchae inside of our nasal cavity. Now, these are also called turbinates, just in case you see it on an exam or in a different book. So conchae and turbinates are interchangeable. They're the same thing. And as I mentioned, we have superior, middle, and inferior. But only the superior and middle belong to the ethmoid bone. The inferior nasal concha, or turbinate, is its own unique special bone. So the superior and middle. So what we're looking at on the picture on the left is a lateral view. Basically, we did a mid-sagittal cut. So we cut the person's face right down the middle, and then we turned it to the side. So you're looking inside of the nasal cavity. And you see these bumps, these ridges that I'm going to be circling in red. These ridges are the conchae. So the 2 ones that I just circled in red are the superior and middle nasal conchae in the ethmoid bone. And then once again, the inferior is its own unique bone, separate from the ethmoid bone. Now, what these do is they make ledges so we can actually have kind of passageways or valleys so the air that we breathe in through our nose can travel through. So it's kind of just making this cool little funnel apparatus so our nose can funnel the air to eventually to our trachea and to our lungs. But throughout those valleys or passageways, which we're going to cover in just a little bit, they have cells and a lot of mucus that helps warm and humidify the air. Because remember, inside of your body temperature is around what? Should be around 98.6, give or take a degree, right? But if you're outside in 40-degree weather and you're inside of your body's 98.6, when you breathe in that cold air, your body doesn't like it. So right when that air hits your nose, there are actual tissues and cells that actually help warm and humidify that air. And part of that is accomplished thanks to these ledges or these conchae or turbinates. So if you take a look at the picture on the right, you can see the superior and middle conchae. You can see the superior right here, and then the middle one's a little easier to tell on the ethmoid bone right here. So on either side, that would be the middle. So once again, superior and middle belong to the ethmoid bone. Inferior is its own unique bone. All right, so we have covered the cranial bones. We covered the frontal, both parietals, both temporals. We covered the occipital, and then we covered the sphenoid and ethmoid. Now what we're going to do is move on to the facial bones, the bones that make up your face. And the first one that we're going to start with are your nasal bones. And as you can see, and you can probably guess where they're located, they're kind of the what we call the bridge of the nose. So when you break your nose, you typically break these nasal bones. And yes, we do have paired nasal bones. There's a left bone and a right bone, and they are fused right in the middle. So a lot of folks think when you break your nose, it's one big bone, but there actually are two bones in there. Next is the maxillary bones. They're also called maxillae or the maxilla. Very many different ways to describe these bones. So these are the upper jaw bones, but as you can see, they're a lot more than that. They are known as the keystone of the face. So remember, the keystone of the cranium, we called the sphenoid bone that. And the reason why we called it that is because the sphenoid bone kind of touches all other bones, right? Frontal, parietal, temporal, everything around it is touching the sphenoid bone. And it's the same principle here with the maxilla or the maxillary bones. We call this the keystone of the face because it pretty much touches every single bone that we're going to talk about in your face, except for your lower jaw bone, your mandible. But every other thing, I mean, you can see it's touching the nasal, it's touching the zygomatic bones that we've already talked about, and several other bones. So it is the upper jawbone. It's going to hold in all of your teeth in your upper mouth area, but it's way more than that. Really, really cool bone. It's also going to make up part of your inferior orbit. It's also going to protect part of your nose area. And if we were to flip the skull upside down, this bone is actually going to make a big portion of the roof of your mouth, or what we call the hard palate as well. So a few important bone markings for the maxilla or maxillary bones. One are the alveolar processes, and the alveolar processes are the indentations. They're the depressions where your teeth are being housed. So literally you can define this as your tooth socket. And if you haven't had any teeth pulled or anything and you're an adult, you should have 16 teeth in your upper mouth area. So you should have 16 alveolar processes as part of this maxilla bone. So literally just a tooth socket. The next bone marking are the infraorbital foramens, or foramina for plural. And these two, we've already covered the supraorbital foramen, right? So supra meaning superior, and orbit is the eye socket. And then remember what a foramen is. A foramen is a hole. So it's the hole above your eye socket. In this case, in the maxilla, we have infraorbital foramen. So it's the hole below the eye socket. And you can see on either side of the face, we have these two openings. And it's going to be the same thing. We're going to have blood vessels and nerves going in and out of that hole. Next, we have the palatine process of the maxilla. And to get your orientation right, what we're looking at is an inferior view of the skull. So we're looking at the head upside down. So you're looking up into the upper mouth, the roof of the mouth, also known as the hard palate. So that structure highlighted in red, that is still maxilla bone. As you can see, if you take a look in green, I'll highlight the teeth of the upper jaw. These are your teeth. So holding in all those teeth is still maxilla bone. So the area between that is still also the maxilla. Now what it's going to do is it's going to connect with the rest of the hard palate, and that's going to be called the palatine bone. And I'll put that in purple. Back here would be the palatine bone. So the palatine bone and the maxilla bone connect in the roof of your mouth. And we'll talk about that process when we get there. But the palatine process of the maxillary bone, the anterior portion, roof of your mouth, right in between all your teeth. And then one last pair of sinuses for you, and then we'll be done with sinuses. We also have maxillary sinuses, and these are the largest in the face. And you can see on both angles, these are the kind of light blue looking structures. So on either side of the nose, right where that maxilla bone is, so it should kind of make sense. And then you can see from the lateral view, definitely the largest out of these 4 types of sinuses. So just to recap all the sinuses, number 1 in green, those are the frontal sinuses. Number 2 in purple, those are the ethmoid sinuses. Number 3 in red, that is the sphenoid sinus. And then number 4, or in blue, are the maxillary sinuses. Next, we have the zygomatic bone, and this is also known as your cheekbone, as you can take a look at the picture. And once again, this is going to connect with that zygomatic process of the temporal bone. So in red, I'm highlighting the zygomatic process, which is part of the temporal bone. And then you put those two together, we get something called the zygomatic arch, as we've talked about before. Next, we have the mandible. This is your lower jaw area. It's going to hold all of your lower teeth. So we're going to have the same thing as you saw in the maxilla. We're going to have alveolar processes, or aka your tooth sockets, and we should have 16 of those as well inside of our jaw. As you can see on the bottom, the largest, strongest bone of the face, that is very true. You have 2 muscles on either side of your jaw, very, very powerful muscles that help you chew. So strong muscles attached to strong bone. This is a very strong area of the human body. Couple bone markings for the mandible. We have the mandibular condyle. We've mentioned this a few times so far in this lecture. Remember, usually a condyle is kind of this rounded bump, smooth surface looking thing, and that's going to fit into a groove depression looking thing called a fossa. So we have the mandibular condyles highlighted in red, excuse me, highlighted in red, and they're going to fit inside of the temporal bone called the mandibular fossa specifically. And that's going to make your jaw joint, what we call that is the temporomandibular joint, also known as the TMJ area. So if anybody has TMJ dysfunction or TMJ disorder, it just means where your jaw meets your head, there's something off. A lot of times it's just a little off track, a little crooked. And if you go to a really good dentist, they can actually correct that for you, believe it or not. And then, of course, we have the alveolar processes, and the alveolar processes, once again, are just your tooth sockets. It's just the area of bone that literally holds your teeth in place. Other bone markings include the mental foramen, and you have one on each side. So what we're looking at is an anterior view of the mandible, and you can see highlighted in red with the green arrow are these 2 little holes. And same thing, usually 99 out of 100 times what a foramen is, it's going to be a hole that allows blood vessels and nerves through, and it's the same thing here. So it helps you feel your face. So on the last slide, we just covered mental foramen, and that's kind of on the anterior part where your chin is. On the posterior side of your mandible, and kind of inward, is another pair of foramen. We have the mandibular foramen. So on this picture, you can only see one of them, but there is one on the other side as well. So you have a left and right. And it's the same thing, blood vessels and nerves. But this is really, really important, especially if you're getting dental work in the back of your jaw, for example. You're getting any kind of root canal or work done, crown in the back, or you're getting a tooth pulled back there, you want to be numb in that area because that pain is unbelievably insane, very, very severe. So what you have to do is you have to kind of numb the immediate area, right? You have to numb the gum area, gum line, but you also need to just numb the whole mouth at that point. And that's where the dentist usually sticks you with the Novocaine or the local anesthetic, just to numb everything. It's right where that nerve comes out in that mandibular foramen area. Moving on from the mandible, we have the two lacrimal bones, and the lacrimal bones are just really small bones just lateral to the nasal bones. And these have this really cool indentation called the lacrimal fossa, which basically allows us to help drain tears into our nasal cavity. So that's why every single time you cry, you eventually get a runny nose, right? It's because your tears have to drain somewhere, and a lot of times if they're not coming out of your eyes, they drain into your nose. So that's with the help of the lacrimal bones. Next are the palatine bones, and we've already talked about the palatine bones a little bit, but take a look at the anatomy of the palatine bone. It's kind of funky looking. If you look at the picture on the right, you'll see that we have a left palatine bone and a right palatine bone. They kind of make these L shapes towards one another, and where they combine, they kind of make this U looking structure. So we have the horizontal aspect, or the bottom of the U, and what that does is that forms the posterior portion of the hard palate, which connects to the palatine process of the maxilla bone. So the whole roof of your mouth is made up of two different bones. And actually, truthfully, it's four, because we have a left and right. So we have a left and right maxilla, and we have a left and right palatine bone. So four bones make up the roof of your mouth. And then where we have this up and down, or this vertical portion of the palatine bones, what that does, that's actually going to go up into the nasal cavity area and help just support that area. Then we have the VOMER bone, another odd looking irregular shaped bone. You can see from the anterior view on the right, it looks very, very tiny. It is, it's tiny. But if you look at the lateral view on the left, it is long. So it does take up a good amount of space. And this is the bone that makes up the remainder of your nasal septum. So what we said earlier was we had the perpendicular plate of the ethmoid bone that kind of goes down. I'll do it in black. If you can see that, there we go. The ethmoid bone, the perpendicular plate specifically, makes the top part of your nasal septum, and then the vomer kind of comes up and makes the bottom portion, and they combine to make it one structure. Speaking of the nasal septum, we'll throw the orbits in there as well. So once again, your orbits or orbital area are just your eye sockets, and we've talked about many different bones that are part of the eye sockets, as you can see. We have our frontal bone, we have our sphenoid bone, we have both zygomatics, we have the ethmoid bone, we have both lacrimals, and we have both maxilla or maxillae or maxillary bones. So a lot of different bones that make up your eye sockets. And you can see once again the eye socket here in red. We got the red circles showing you the eye sockets. And then around the nose area, we're highlighting the nasal septum. And as we just talked about, the upper portion of the nasal septum comes from the ethmoid bone. Specifically, the bone marking is called the perpendicular plate, and the inferior portion is the vomer. So it is actually bone, but like I said, most people think that it's cartilage. It is cartilage. It's covered by cartilage, but the bone actually is there. And that cartilage, when in doubt, as we've talked about before, is hyaline cartilage, right? By far the most common type of cartilage in the body. Just a quick review of the sinuses. Once again, we call these paranasal sinuses. And the reason why para just means around, so all these sinuses are around the nose area, right? So when you have a nasal infection or a sinus infection, generally the area around your nose hurts, whether it's your eye sockets or your forehead or your temples. It just depends where the infection is, right? And as we've talked about before, we have the four sinuses, and they are not in order, but frontal would be number 1, sphenoid would be 3 in this picture, and then ethmoid would be 2, and the maxillary would be 4, if you're going by the color-coded number key on the right. Now, those 4 sinuses that we just covered are the major sinuses of the face head area, but there are other sinuses throughout the skull, and one of them that I do want to bring to your attention are the mastoid sinuses. And typically what you'll see in textbooks and other writings is you'll see these called as the mastoid air cells. And the reason why is because there's just so many of these tiny cavities or holes within the mastoid process, or the mastoid area of the bone. So a lot of times they're called air cells. And similar function as sinuses, they lighten the weight of the skull, but they also are right next to that eardrum area, so they do help with communication of sound waves in that middle ear, specifically right next to that eardrum. And then we arrive at the turbinates again. These are once again also called conchae, C-O-N-C-H-A-E. And we have, and you can see in the picture on the right, that the superior and the middle conchae are part of the ethmoid bone. And then the inferior nasal concha is just its own unique bone. So the purposes, once again, are to make those ledges. We had 3 ledges, superior, middle, and inferior. And what that does is allows it, if we have 3 mountains, between those 3 mountains, we're going to have these valleys or passageways, and that is going to allow air to move through our nasal cavity. And as they move through those passageways, and if anybody's ever gone hiking in the mountains before, you know that the wind changes if you're between mountains. It allows us to warm, humidify, and clean the air as well. So we actually have cells, we have mucus cells, goblet cells that actually help create mucus environment in that area as well. And then at the bottom, once again, you can see the inferior turbinates. So you have a left and right. They're their own unique separate bone. Same function as the superior and middle conchae, but is its own unique bone, not part of the ethmoid bone. Okay, so other than the ear bones, we have covered every single bone in the face skull area. So before we move on to the ear bones, let's just cover a few more important aspects of the skull. And one thing, first, are the sutures. And sutures, as you can see, are immovable joints between the skull bones. So when we are born, the bones of our skull, that outside cranial area, are not completely locked together. So the frontal bone is separate from the parietal bone, separate from the temporal and occipital bones. And so that's why the baby's head is really, really soft. And basically it allows for the baby's head to be squished during the birthing process, right? If we're having a vaginal delivery, there's a lot of compression on the baby's head during that time frame. Also, what do babies do nonstop? Well, 1, they sleep for like 18 hours a day, but 2, they're growing constantly, right? So in order for our brains to grow, we need a little give, we need a little space. So we allow that to happen. As we start aging, though, and our head starts forming and taking shape, we start locking these bones together to completely protect the brain the best we can. And what these joints or what these connections are called are sutures. So we're going to take you through 4 important notable sutures on the next several slides. The first one is called the squamous suture, also known as the squamosal suture. And what this is, I'll draw it in red for you, or you can see it in the black arrow too, right? This is a suture that connects mainly the superior part of the lateral skull to the inferior part of the lateral skull. So it's connecting your parietal bone to your temporal bone. Now you can see also, though, we have aspects of the sphenoid bone right here, but for the most part, it's separating parietal from temporal. That's called the squamous suture. So we have one on the left and one on the right. Another suture we have is called the lambdoidal suture, or the lambdoid suture. And what we're looking at here is the back side of the head. So you're looking at the occipital bone in this kind of blue, green, teal color. And the lambdoidal suture, is this structure in red. So mainly what we're doing here is we're separating the occipital bone from all other bones. So you can see we have a left parietal and a right parietal. We also have that left temporal and right temporal as well that we're separating, called the lambdoidal or lambdoid suture. Another suture is the coronal suture, also known as the frontal suture, and that is making kind of a coronal or frontal cut along the skull, if you will, and that's just separating the frontal bone from the two parietal bones here. And then last but not least, we have the sagittal suture. And the sagittal suture, if you were to take a mid-sagittal line and just cut it across the entire mid part of the skull, that's what you would get. So what we're looking at here is the very top of the skull. Here you would see the frontal bone. On the very, very back, you would see the occipital bone. So these two bones on the left and right, respectively, are the parietal bones. So this area shaded in red is the sagittal suture. Now we'll talk more about these joints specifically, like what's actually binding them together, why are they all zigzaggedy in the next chapter when we cover joints. But for now, just know those four sutures. We have the squamous, lambdoidal, coronal, and sagittal. They're not in any particular order. Okay, so everybody's a little different, right? We all have different fingerprints. Sometimes folks have a supraorbital foramen. Sometimes folks have a supraorbital notch. Sometimes folks have a crooked grin. Some folks have one eye socket or eye that's lower than the other. We're all just a little different. And because of that, our sutures can be a little different as well. And when our sutures don't join exactly like I just described on the previous four slides, what we get are these little island bones called Wormian bones. And as you can see in this picture here, what we have is our, for example, our squamous suture in red, and then we have part of our lambdoidal suture in green. But what happened was we had extra sutures kind of form, and we have more than just the four types of sutures I mentioned, but those are the four main ones. And what happens is sometimes these sutures can kind of isolate themselves and create these little islands or these other bones. So some of you have more than 206 bones in your body, if we're being really nitpicky. And you can see another example right here with that coronal and possibly the sagittal suture involved. So everybody's a little different, everybody's unique, and really the only way you can figure this out is if you take an x-ray of your head and look at the different suture markings. Now that we've covered sutures, we can talk about the spots before the sutures actually close, and what those spots are called are fontanelles. And these are also known as the soft spots on the baby's or the infant's skull. So it's the areas where the bones have not fused yet. And what we call that fusing or that growth of bone is ossification. Or remember, calcification, same thing typically. So the purpose of this is to allow compression of the head during childbirth, like I mentioned. Also, it's to allow the baby's brain to grow, right? We got to give it some space because it's going to get a lot bigger. So those are called fontanelles, and you have them where the sutures are not fully formed yet. So to cap off all the bones in the skull face area, we have to wrap it up with the ear bones. Now, a lot of times these ear bones are also known as ossicles or auditory ossicles. So auditory meaning hearing, and ossicles are just the specific type of bone. And what we have is a very specific order here. So as sound waves are traveling into your external auditory meatus through your temporal bone, right? The first structure that it actually hits is this dome-looking structure called the eardrum or the tympanic membrane. And the big part about hearing, it's all about vibration. It's all about waves vibrating and moving through air and then eventually fluid. So what happens is those sound waves vibrate and they hit the eardrum, and then all of these structures are connected. So the eardrum vibrates and it hits this first bone. And this first bone is called the malleus bone. It's also known as the hammer bone in layman's terms, because what happens next is the malleus bone vibrates and it hits it already articulates, but it hits and sends those sound waves to the incus bone. And the incus bone is also known as the anvil, so it kind of makes sense that the hammer bone hits or bounces against the anvil. And then you kind of get where we're going here. The incus bone vibrates and hits our last bone called the stapes bone. And the stapes bone is also known as the stirrup, because if you take a look at the picture of the bone, it kind of does look like a stirrup, right? So we have 3 of these in each ear, so we have a total of 6 ear bones. And it goes in that order. It kind of goes in regarding sound wave production. We have malleus, incus, stapes, and then eventually it's going to go to structures in the inner ear and then eventually to our brain so we understand what we're hearing. But if you remember MIS, you'll remember the order for later on and just the orientation of these bones. So malleus, incus, and then stapes. So now what we're going to do is we're going to cover this very unique bone, this irregular bone called the hyoid bone, and then we're going to move on to the vertebral column or your spine area. So the hyoid bone, really, really cool. It's this kind of U-shaped looking bone right in the middle of your neck. And it's literally smack dab in the middle of your neck, right between your jaw and your larynx. And what your larynx is the area where you have your vocal cords. Also, it's kind of where your food tube and your air tube get separated, your esophagus from your trachea, so we don't have food going down the wrong pipe or water going down the wrong pipe. Now, very unique characteristic to the hyoid bone is this is the only bone out of the 206 bones in the body that we're going to cover. This is the only bone that doesn't touch another bone. Even those tiny, tiny little ear bones actually touch other bones, right? The malleus touches the incus, and the incus touches both the malleus and the stapes. So every bone in the body is touching at least one other bone except this. This bone, the hyoid bone, is only held in place by ligaments and muscles. Now, there's a very, very important function to this hyoid bone. You have to have it because it serves as a very important area for those specific muscle attachments that form the floor of your mouth, kind of the bottom of your mouth area, and your tongue. So it'd be very, very hard to articulate and move your tongue if those muscles don't have a solid attachment point. So that is the hyoid bone, kind of smack dab in the middle of your throat. Okay, next topic, we're going to cover the spinal column. And remember, with the spinal column, we have 24 vertebrae. So we have bones in our neck, mid-back, low back. And then we have 2 other bones. We have our sacrum bone, which is going to be kind of this big triangular looking bone. And then we have another weird triangular bone, our tailbone, called the coccyx. So you add those all together, we get 26. Just big picture before we dive into any more detail. Remember, this is all still axial skeleton. Anything dealing with the skull and the face is axial skeleton. The hyoid bone that we just covered, smack dab in the middle of your body, axial skeleton. Also the spine, smack dab in the middle of your body, that mid-sagittal line. So this is still all axial skeleton. Let's begin with the superior portion of the spinal column, and we'll just work our way down inferiorly. So first are your neck bones, and we call these the cervical vertebrae, and there are a total of 7 of them. And the good news is there's only 2 unique ones that actually have specific names, and then every other one is just the number of it in order of the spine. So really it goes C for cervical and then the number 1, and then under that is C2, C3, C4, and it goes all the way down to C7, and that's how you actually number the vertebrae. As I mentioned, there are 2 specific vertebrae that have unique names. So one of them is called the atlas bone. This is also known as C1, or the first cervical vertebra. So this is what's actually going to be articulating or joining with those occipital condyles. So you can see here on either side of the atlas, we have these kind of indentations. Now, we don't exactly call them fossae or a fossa, but that's what they are. They're just a groove or depression, and the occipital condyle is going to fit inside of those to join our head and neck. So this area right here in purple with the star, that's going to be what we call our spinal foramen or our vertebral foramen. But as we talked about with the occipital bone, it was known as the foramen magnum. So that's kind of right where those two structures are joining together. And the reason why they call it the atlas bone is if you have to go back to Greek mythology to learn about this guy named Atlas who did something really bad. I used to know the story, but I forgot. He messed up big. He lied or cheated or did something. And his punishment for all of eternity was to walk like up a hill carrying the entire planet Earth on his head, like on his shoulders. And if you Google Atlas Earth, you'll see this really jacked muscular guy carrying the Earth. But that's basically what your atlas bone does for you, is it carries your world or your brain on top of its shoulders. So if you were to fracture this bone, you would have severe cervical instability and possibly death, or like I mentioned earlier, severe paralysis, because the brain wouldn't be able to connect or communicate with the rest of the body very well. So that is the atlas bone, also known as C1. The next bone in the cervical vertebrae is known as C2, also known as the axis bone. And the reason why is because of this structure here in purple. This is called the dens, and the atlas bone, kind of like I just drew on accident, but the atlas bone sits around that dens and it can rotate and pivot around it. So it pivots around it like an axis, so that's where they got the name. So this is what allows you to say no. If somebody asks you a question and you shake your head to the left and right, what's allowing you to move your head in that specific direction is this joint between C1 and C2, atlas and axis, with this pivoting motion. And as I mentioned, the rest of the cervical vertebrae are just what we call typical vertebrae, and they just are named and numbered after their order. So we have C3, C4, C5, C6, and then C7. And then as soon as you get past C7, we are introduced to the thoracic region of the vertebral column or the spinal area. And we have a total of 12 of these. And this is really easy to remember, this 12, because we have 12 pairs of ribs that actually join on each side. So we have left and right ribs, and each pair joins with its respective thoracic vertebra. So you have the first ribs are touching T1, the second ribs are touching T2, and then it just kind of goes in that order. And then last but not least, we have the lumbar vertebrae, and the lumbar vertebrae is commonly associated with your lower back, and we have 5. And a good way to remember this, in case the numbers are kind of overwhelming you, we have 7 cervical, we have 12 thoracic, and we have 5 lumbar. And if you remember that typically they're all 5 hours apart. For example, if you picture a clock, typically you eat breakfast at around 7, right? You eat lunch at around 12-ish, and then you can maybe eat dinner at 5 o'clock, all 5 hours apart. Breakfast, lunch, dinner, 7, 12, 5. And if you add all those numbers up together, you get the total of 24 vertebrae in your spine. Now, inferior to the lumbar vertebrae, we have the sacrum and the coccyx. So in this slide, let's just focus on the sacrum. The sacrum is just kind of this triangular looking bone right here. So this would be the anterior, the front view of it. This would be the posterior view. And when we're born, these are actually 4 to 5 separate bones. So there actually are places where there is a disc of fibrocartilage, and these are separate bones. But as we age into childhood and adolescence, teenage years, and all that stuff, they eventually start fusing together. And by the time you're fully grown, 18, 20, 22, whatever age you are fully grown at, these bones are generally completely fused, and they just make up one big bone. Every once in a while you'll get an anomaly where 2 of these 5 bones don't fuse together, and that's okay. But for the most part, they fuse into this one big solid mass called the sacrum. And then we have the most inferior aspect of the vertebral column, and that's known as the coccyx. And the coccyx is just inferior to the sacrum. Also looks like this kind of inverted triangle. This is also known as the tailbone, and it's the same thing as the sacrum. Typically 3 to 4, maybe even 5 vertebrae are separate at birth, and then as we start aging, they fuse into one solid bone known as your coccyx. So let's talk about a few characteristics of typical vertebrae. We saw some weird ones such as the atlas and the axis, but for the most part, the other 22 vertebrae are kind of similar regarding these landmarks or bone markings. So let's get our orientation right. This picture on the left, we're looking at a lateral view or a side shot of the vertebrae. So we have 2 vertebrae stacked on top of one another. And then this picture on the right, we're looking at a superior view. Basically, we're looking down at a vertebra. So this would be the anterior aspect of the vertebra, and this would be the posterior aspect of the vertebra. So let's identify some structures or some land markings, bone markings. We have the body of a vertebra is basically this flat rounded area in green with the stars. So we have big bodies for every single vertebra, at least the typical vertebra. We have a spinous process. We've actually already introduced that. The spinous process will be here in purple. These are the things that you can actually feel in the back of your neck, back of your back, if you touch your spine. Once again, process going to have a lot of muscle attachment in that area, right? And then we have the transverse processes. And the transverse processes kind of work transversely or horizontally. They kind of move out to the side. So we'll do that in black. You can see a couple at least them on this side, transverse process, but you can really see them well here. These structures kind of protruding out to the side are the transverse processes. And same thing, we're also going to have muscle attachment in this area. So in the cervical spine and the lumbar spine, it's mainly just going to be muscle attachment. In the thoracic spine, it's going to be both muscle attachment and rib attachment with these transverse processes. A lot of times we abbreviate them as TPs, transverse process. Other important bone markings for the vertebrae are the superior and inferior articular processes. Now, big crazy term, but not that bad. Superior, you know what superior and inferior means, right? Superior is closer to the head, inferior is closer to the feet. Articular or articulation means joint. So basically, these are the facet joints that we introduced earlier in the chapter. This is where the posterior portion of the spine actually joins together. So we call them a process, right? Something that sticks out. And on the vertebrae, you have a superior articular process on the left and another one on the right. And same thing, you have an inferior articular process on the left and on the right. And basically, just picture stacking Legos to make a tower. All we're doing is we're taking these articular processes and joining them together. So if I have a vertebra, we'll look at the bottom right corner with me for a moment. And I have an inferior articular process. Just above that is going to be a superior articular process. And let's call this L5. Then on top of L5 is going to be L4. So what joins with the superior articular process is the inferior articular process of L4. And then that's going to have a superior. And then on top of L4 we have L3. L meaning lumbar, right? Lower back. We have the inferior process of L3 joining with the superior of L4, and then we have a superior up here, and you see where I'm going with this. And then you have L2, inferior, superior, and it just keeps going all the way up to the top of your neck to join with your head. So that's really it. It's just how these bones are connecting. And then last but not least, we have the spinal foramen, also known as the vertebral foramen. and we already know what that is, right? We know a foramen is a hole, and in this case, this hole is very specific because this is where the spinal cord is going to be passing through. So usually with the foramen, we're going to have nerves and blood vessels. Here we have a whole lot of nervous tissue, specifically the spinal cord, passing through. Another important topic of the spinal column are the curves. So very important. If you look at the first bullet point, it says the spinal column is curved, not straight. I want you to be careful with that statement. It's true and very, very false at the same time. The spinal column is curved, yes, from a lateral perspective. Okay, if you look at this picture on the right where I just drew the arrows, yes, you do want curves. If you don't have curves, you're going to have some arthritis issues, you're going to have some pain going on. But please don't make the mistake that an ideal spinal column from an anterior to posterior view or posterior to anterior is very, very straight. The straighter your spine from a front to back view, the healthier, the better you're probably going to be. Anytime where we get curvatures or misalignments of the spine, that's where issues start happening. So yes, the spinal column is curved, but from only a lateral perspective. Cool? Okay, so now that we got that straightened out, we can talk about the importance. Why are there curves? So the reason why the spine is not completely straight from a lateral view is because there's a huge compression factor. If I was to align all these bones, so basically I'm redrawing this spine on the right, but I'm stacking them where there's no curves, every single time you do something that causes stress or strain on the spine, those forces go straight down. And one of them you can't help, you can't fight, is gravity. Right? Gravity is constantly pulling down on us, keeping us on the ground on planet Earth. And months and months and years and years and years of gravity and lifting heavy things and jumping up and down and walking on hard surfaces will cause breakdown of your spinal column, and you will get arthritis and you will have painful issues. So what your spine naturally does is it curves itself, and it kind of makes these S shapes all throughout the different regions, and what that does is it kind of spreads out the impact and it dissipates all of those harmful forces, so you can jump up and down, you can walk on hard surfaces, and you can live on planet Earth for 60, 70, 95 years and be okay for the most part. So that's the purpose of those curves: strength, balance, protection, and you see from FX, from fracture, right? Because if we have too much pressure on the bones, eventually as we get older, they can break, they can't fracture. But it's also other structures are involved, such as the discs. That fibrocartilage does break down as we age. It gets weaker. The hyaline cartilage between the facets gets weaker. The ligaments, muscles, tendons, they all get weaker. So we want to minimize that impact. So we have two different types of curves with the spine. We have what we call primary curves and then secondary curves. So primary means you're born with it. These curves are, they appear first. How about that? So if you picture how we are in mom's womb for the most part, we're kind of in the fetal position, kind of all curled up. And this is really easily seen in your mid-back, your thoracic region, and the sacral region. Sacral, including the coccyx as well. So what you have is you have these two, what we call kyphotic curves, meaning that they're convex if we're, well, we won't get into convexity and concavity, but they go this way. Oh, it does say convex. Okay, so we can talk about that. So convex regarding a straight line would just mean it moves outward. So if you stand straight up, your thoracic spine should be bending towards or outward towards your posterior aspect of your body. And same thing with your sacrum. Now the secondary curves are concave, and these are called secondary because you're not born with them. You have to develop them. So they're the opposite direction. So they actually kind of curve in. And the best example, you can feel this with your low back, right? A lot of folks have a curved low back. They kind of stick their posterior hips out a little bit more than others. A lot of times when you lift something heavy and you brace your back, a lot of times you want to increase that curve or at least flatten your back so it's not damaging to those areas. So how we develop them is through living life. Number one, you can see how we develop the cervical curve is babies eventually learn to hold their head up in order to see, right? Because otherwise they're just on the floor looking at the floor the whole time. In order to see what's going on around them, they eventually have to learn how to pick their head up. And by naturally picking up that big, heavy head, they're going to create this curve in their cervical spine. And what we call this is a lordotic curve, or lordosis, or concave, as you see in the notes. And then your lumbar spine develops a little bit later. It says develops as a child learns to walk. It actually starts developing when you learn to crawl. If you've ever seen a baby crawl, their lower back does sag a little bit, right? So you do start developing that during the crawling phases, and then it's finalized during the walking phases when you have to hold your body upright. So thoracic and sacral are primary because we're born with them, and the cervical and lumbar are secondary because you have to work on them. You have to develop them after birth. With this slide, we'll cover some abnormal curvatures of the spine. So 3 different situations that can happen with the spine. With the first picture on the left, we're looking at something called a scoliosis. So remember that from an anterior to posterior or a posterior to anterior view, the spine should be straight. Try to draw a straight line, kind of easier said than done, but it should be up and down straight. Bunch of Lego blocks, one on top of one another. When the spine is curved from this anterior to posterior, posterior to anterior orientation, that is what we call scoliosis. So you can see in this picture that I'm tracing in red, when we get this kind of S-looking shape in the spine, that is abnormal bending, and that can cause some issues with the joints, which can cause some issues with the muscles, and if severe enough, it can even cause some breathing issues. But mainly with folks with scoliosis, you're going to see some postural differences. One leg is going to be shorter than the other. One shoulder is going to be higher than the other. Some ribs on one side may protrude out more compared to the other side. So somewhat noticeable. Now, there are such things as a asymptomatic scoliosis. Some folks have tiny little curvatures to the right in their thoracic spine due to the heart taking up so much of the left thoracic cavity area. A big portion of your heart, it is in the middle of your chest cavity, your thoracic cavity, but the left side of the heart is a lot bigger than the right side of the heart. So every once in a while, you'll see somebody with a tiny curvature to the right, and they're asymptomatic, there's no problems, no big deal. It's when you get this S shape going on is when symptoms can unfortunately arise. When you look at the next 2 pictures in the middle and on the right, we're looking at abnormal curvatures. So remember, we are supposed to have convexity and concavity. The convexities occur in those primary curvatures, the thoracic area and the sacrum area. And we call that a kyphosis, or I called it a kyphosis on the previous slide. So a kyphosis is normal. You do want curves in your thoracic spine and in your sacrum. However, when those curves get too out of whack, too crazy, then they can become abnormal. So we would call that an abnormal kyphotic curve. And you can take a look at this picture, this gentleman in the middle, where this roundedness of the middle back is a little extreme. And what that's going to cause to happen is the head dips forward, which causes neck and muscle issues, specifically in the shoulders and neck area. So you see this, it's very, very common in the elderly. As the joints start getting weaker, start breaking down as we age, generally everything just starts kind of moving forward and encroaching forward. The shoulders round out, the head kind of leans forward, and you kind of get this excessive kyphotic curve in the thoracic spine. Not really good for breathing, right? Kind of lean over like an elderly person, or like on, typing on a laptop, and try to take a really deep breath. It's a little harder compared to standing upright. And then the last picture is talking about lordosis or a lordotic curve. And same thing, you do want lordosis curves in your spine, specifically in your neck and in your lower back. That is normal. It's when those curves get too crazy, when those concavity curves get too excessive, it's when they can become an abnormal lordosis or an abnormal lordotic curve. So you can get this in the neck. It's kind of rare. You have to really work hard to get this in your neck, but it's very, very common in females in the lumbar region, especially when a female is pregnant. Right? Because just think about the center of mass, and what's happening during pregnancy is you have this baby that's growing, and yes, the baby can be anywhere from 3, 4, 5 to 9 or 10 pounds, but you also have to consider the weight of the placenta, the amniotic fluid, the blood flow, all that stuff. It's a lot more than 10 pounds. So all that stuff's kind of pulling you forward. So what happens is the spine has to compensate to keep you balanced. So you kind of get this overarching of the back. Now, the good news is that can go away after the baby's, born. But other things that can cause this is weight gain, too. If you have a lot of weight in the front part of your belly, that can also cause the same effect as a pregnancy. So that's an abnormal condition. Okay, so we have covered the spine, we've covered the hyoid, we covered all the facial and skull bones. The last part of the axial skeleton that we need to cover is the sternum and the 24 ribs. So you put that all together, we have 25 bones. And the good news is the ribs are just ribs. They don't have any crazy names to them, so we'll get to fly right through this. First, let's discuss the sternum. The sternum is right in the middle of your chest, and it basically anchors the majority of your ribs together on the front side of your thoracic cavity. And it's also known as the breastbone, layman's terms, but you're going to obviously need to know sternum. We have a few markings of the sternum that we need you to know. The sternum can be separated into 3 parts, and I'm going to kind of draw those 3 parts for you right here. So the most superior portion of the sternum right here is called the manubrium, and the manubrium serves as a really great place for your clavicle, your collarbone, to actually attach to, so you can move your arm. The middle portion, or the main portion of the sternum, you see this word body again, right? Body is just the main portion of a bone typically. And then we have the xiphoid process. Weird spelling, it's pronounced xiphoid, and this is just this little tip of the sternum. Typically, it just depends. As you can see in the notes, composed of cartilage. When in doubt, what type of cartilage are we thinking? Right, hyaline cartilage. But as we age, typically it does ossify, it does become bone, but that's not always the case. A lot of times, in some folks, it can just stay cartilage forever. So it just depends. And then connecting to the sternum is not the ribs themselves, it's actually cartilage. So if you take a look at the picture on the right, all of this tissue connecting to the sternum is not bone tissue, it's cartilage. And what we call that is costal cartilage. This term costal refers to ribs, so it's rib cartilage. And once again, between the 3 types of cartilage, fibroelastic or hyaline, this is going to be hyaline, right? Most common cartilage throughout the body. Okay, with the ribs, nothing too crazy. We have 12 pairs for a total of 24. The top 7 pairs, or the superior 7 pairs, are what we call true ribs. And what that means is that rib has costal cartilage that connects directly to the sternum. So I'll do a rib in black, and then here's our sternum. And then orange would be the costal cartilage. So for every rib we have, it's directly connected to that costal cartilage that is directly connected to the sternum. So that's what we call true rib. For ribs that have costal cartilage that doesn't directly connect to the sternum, those are called false ribs, or they don't touch the sternum at all, are called false ribs. So let's take a look at how this looks. What we have is we have a few ribs down here, and their cartilage all fuses together to make this kind of one big mass of cartilage. And then that cartilage is what touches the rib. So you can't make the distinction between which rib owns that cartilage. They're all kind of fusing together. So because they're not directly touching it, we call that a false rib. Now there is a difference between the upper 3 pairs of ribs in the false ribs and then the lower 2. And the upper 3 is what I just drew you. They indirectly touch. They do touch the sternum, but they kind of fuse costal cartilage, or they share costal cartilage. And then last but not least, the 11th and 12th ribs, they don't touch the sternum at all. They're just kind of hanging. What we call these are floating ribs. And really their only function is muscle attachment and to protect a little bit of your kidneys. But even then, they don't do that great of a job. So summarizing all this up for you, what we have is we have 7 true ribs, put T for true, and we have 5 false ribs. But then out of these bottom 2 out of those 5 are what we call floating ribs. So a floating rib is a false rib, but a false rib is not necessarily a floating rib. I'll say that one more time. All floating ribs, so we have 2 pairs, 2 on the left, 2 on the right. All floating ribs are false ribs because they're not directly touching the sternum. But not all false ribs are floating ribs because these top 3 out of the 5 do touch the sternum. They just work together to touch the sternum. So those are your ribs. Last slide for the axial skeleton, just bringing it all together. So as I mentioned earlier, all 12 pairs of ribs, they connect to the thoracic vertebrae, specifically that transverse process area. So that's what kind of makes your rib cage on the back side. And then on the front side, they connect to the sternum. So when you put all that together, the sternum in the front and then the vertebrae and the back connecting all those ribs, you get our thoracic cage. And that's vitally important because what organs are found in that area are your heart and your 2 lungs, right? We definitely need to protect those vital organs. So that's how the sternum and ribs work together, and the vertebrae. Okay, at this point, we have covered the entire axial skeleton. So we have 80 bones knocked out. You've covered a total of 80, and we have 126 left in the appendicular skeleton. So let's get started. First, we're going to begin with the upper extremities, basically the arm bones, and then we'll do the hips and leg bones last. First bone we're going to introduce is what connects the sternum to your upper arm area, and that's called the clavicle. In layman's terms, you may have heard it referred to as the collarbone, right? But we definitely need to address it as the clavicle. And what we're going to do in just a second is we're going to combine it with our shoulder blade bone called the scapula bone. And what that's going to do is form a very important joint called the AC joint. And what that stands for is the acromioclavicular joint. The acromion is just this tiny little piece of the scapula. I'll try to point to it for you. There we go. This area right here, and you can feel this on your own shoulder, basically just the outside of your shoulder. You kind of just trace your collarbone and then work it all the way to the very, very outside part, and you'll feel this bump. And that's where the acromion process and the clavicle kind of meet, and also known as the AC joint. And when you put these 2 bones together, they form what we call the shoulder girdle, also known as the pectoral girdle. And this is what allows you to move your shoulder joint. So if you were to ever sprain or dislocate this joint, you'd have a very, very hard time actually moving your arm. So here are the scapulae. Scapula, if we have 1 bone. These are also known as your shoulder blades. And as I mentioned before, now you can really, great picture, you can really see the acromion process. This structure right here, just this tip. is the acromion, and then wrapping around in the front that I'll highlight in purple is the clavicle. So you can really get an appreciation for that AC joint right there that actually makes your shoulder girdle. There you go. Shoulder girdle, once again, also known as the pectoral girdle, but it's just this combination of these two bones that allow us to move our arm, move our shoulder. All right, a few scapula bone markings that we need to be familiar with. Number one is the spine of the scapula. So the spine of the scapula is kind of highlighted in red. In this picture specifically, it's really showing muscle attachment, but this whole structure in red is called the spine of the scapula. And this is on the back side. So what you're looking at is a posterior view of the scapula, of the shoulder blade. And you can feel this on your body very easily. Just kind of feel the back of your shoulder blade and go across. You'll feel this nice ridge. That's the spine. And we're going to have all sorts of different muscle attachments on it, above it, and below it. A lot of your rotator cuff is oriented right around this spine of the scapula. And the next bone marking we have is the glenoid cavity. It's also known as the glenoid fossa. And that's this kind of indentation or groove looking structure right here. And that is where the head of the humerus, the head of your upper arm bone, is going to actually fit in just a little bit. And here's your humerus right here. So these are the bones of the brachial region, or your upper arm. And we'll talk about some bone markings on the next slide. So several bone markings that you need to be aware of in the humerus. First, the easy one is the head. The head of the humerus is the most proximal part. So that's what's going to be fitting inside of that glenoid cavity or that glenoid process. Next, we have the epicondyles. And remember what epicondyles are. They're just processes for muscle attachment. So usually they're found just a little proximal to condyle-like structures. So the medial epicondyle is going to be these two bumps right here. So what you're looking at is this is an anterior view of the humerus, and this is a posterior view of the humerus. And how I knew that was medial was, one, the medial epicondyle is very prominent compared to the lateral epicondyle, but also if you look at the head always goes towards the medial aspect of the mid-sagittal line of the body, always. So whether we're talking about the head of the humerus, the head of the femur, it doesn't matter. The head always is oriented towards the midline. So because the head is on the medial side, anything on this side of the bone is going to be medial. Anything on this side of the bone will be medial as well. So the medial epicondyles, I'll try to just make it subtle. These big bumps in green for muscle attachment. The lateral epicondyles, same thing. They're just going to be on the opposite side. So we're going to have, it's going to be this area right here in orange would be the lateral epicondyles. And then we have these condyle-like structures in the humerus, but instead of calling them medial and lateral, we do have specific names. So we have the capitulum and the trochlea. And what's very, very important is to make sure you know which one is on the medial side and which one is on the lateral side. And once you learn the forearm bones in just a moment, that'll help you kind of get it straight in your head as well. So the capitulum bone, or sorry, the capitulum, part of the humerus bone, what that is it is the lateral knob that articulates with the lateral bone, which is the radius. So I'll put an R there for radius. And where that's located is right here, this little knob that I'm highlighting in red. And you actually can't see it very well. Well, it would be right here, but it's kind of hidden with a posterior view. The trochlea is the medial bump, so that articulates with the medial bone, which is called the ulna. So that would be this bump here, right here in blue. And same thing, it is hidden. The ulna's in the way. But if we were to remove the ulna, it would be right around that area in blue. So those four structures, the epicondyles and the capitulum and trochlear, really, really close together. When you look at the lab pictures or the bones in lab, make sure you can distinguish the differences between these four structures. So moving distal down the upper extremity, we have the forearm bones, or the antebrachial bones. We call these the radius and ulna. The radius is always on the thumb side, so if we're standing in anatomical position, this is the lateral bone, and that's where we're going to have the capitulum, or where it's going to articulate with the capitulum of the humerus. And then the ulna is on the pinky side, or the medial aspect of the forearm, if we're standing in anatomical position, and that's what's going to articulate with that medial bump, that trochlea on the humerus. So taking a look at this picture, what you have is the ulna is the medial bone. So same thing, we're looking at a front view and a back view. So there, that would be the midline, that crooked line I just drew. So the bones with the U's, those are the ulnas, and then the bones on the outside here, those are the two radius bones. A couple bone markings that you need to be aware of. For the radius bone, we have the head, which is the most proximal looking thing, and it looks like a head. It's just kind of this rounded little structure like that, and then the rest of the bone just goes down. And then at the very, very distal end, at the very, very tip, we have this tiny little needle-like process called the styloid process. And remember, we've seen this before with the temporal bone, right? Right in front of your ear, you have this needle-like thing sticking out for muscle attachment. We call that the styloid process of the temporal bone. And it's no different here. We're going to have muscle attachment in the radius. We're just going to call it styloid process of the radius. When we move on to the ulna, there are three structures that we need you to know. Number one is called the olecranon process. So I'm going to show you this on the next slide, but I'm going to draw you a picture as well. I'm going to draw you a side shot of the ulna. Not the best picture, but okay. So the good way to remember the ulna is it always makes this U shape. If you look at, we're looking at a lateral view of the ulna, and what you're going to get is this nice U shape where the humerus can actually fit in. And what that's called is the semilunar notch. And the reason why they call it semilunar, lunar referring to moon, semi is just part moon, right? It's not a full moon. So we kind of get this crescent looking shape to it. This is also called the trochlear notch because it actually articulates with that trochlea part of the humerus. So semilunar notch, trochlear notch, same thing. Now the back of this, or the posterior aspect of this bump area right here, that would be the olecranon process. And basically, if you just flex your elbow and you feel the back of your elbow, the very pointy, bony part of your elbow, that's what you're touching. That's what you're feeling. It's the olecranon process of the ulna. And then last but not least, same thing as the radius. We have this tiny, tiny structure at the very, very distal end, very small needle-like process for muscle attachment, and it's also called the styloid process. So we'll call it the styloid process of the ulna. Okay, a little better picture here. To give you an idea, let's talk about the radius first. So this lateral bone, right here, this structure would be the head. And then if you go all the way down to the bottom, you'll see this tiny little point on the radius. And that little tiny needle-like point is going to be the styloid process of the radius. So those are the two bone markings we need to know for the radius. Let me clear this out, and then I'll show you the three bone markings that we just covered for the ulna. So what we're looking at here is, once again, this is an anterior view, and this is a posterior view of these two bones together. So this notch right here, where we have this groove or indentation, that is that semilunar notch, also known as the trochlear notch. You can look at the picture, and it's, in this picture it calls it the trochlear notch, and that's because it joins with the trochlea of the humerus. On the backside, the bump of your elbow, once again, is called the olecranon process. And then at the very, very distal part, right next to your wrist, you have these tiny little needle-like things that stick out barely, and that's called the styloid process of the ulna. So same thing, y'all, with these 2D pictures, you can make the differences, make out the differences. However, with a 3D bone, very easy to tell the differences between the trochlear notch and the olecranon process and the head and all those structures. So make sure you get your hands on some bones if you're taking a face-to-face class. All right, next are the carpal bones. The carpals are the wrist bones. We've talked about that before, day 1, chapter 1, right? So you have a total of 8 of them. Good news is you do not need to know the names of those 8, but these are just the bones located in this area. They're very small, short, cube-like bones for the most part. Connected to the carpals are the metacarpals. These are the bones that make up your hand, the palm of your hand and the back of your hand. And you have 5 of them, right? Because they're going to lead to your 5 fingers. And then last but not least, we have the phalanges, or your finger bones of the hand. Now, what I want to point out is that in each finger you have 3 phalanges, except for the thumb. Thumb's a little weird. So if we take a look at this pinky finger, what you have is you have 3 bones. You have that one, and then that one. So we name them based on their relationship regarding proximal and distal. So this first one would be the proximal phalange. The middle one is called the middle phalange. It's also known as the intermediate. Either one would be correct. Put middle. And then this last one would be the distal phalange. Now, if you notice in the thumb, we only have 2. So all we have is a proximal and a distal. There is no middle phalange on the thumb. So total, what you have is you have 3 on each finger. So 3, 3, 3, and 3. So 4 sets of 3 would be 12. And then 2 on the thumb. So you have a total of 14 phalanges in one hand. And then, of course, you have 14 on the other hand. So more than 10% of the bones in your body are simply just finger bones. And once again, we call them phalanges. We're going to see the exact same thing, the identical to this would be found in the toes. All right, we've covered the upper extremity. Let's move down to the lower extremities. First, we're going to introduce the coxal bone. The coxal bone is also known typically in layman's terms as the hip bone. We're going to be a little bit more specific. It's also known scientifically as os coxae, or os coxa being 1. So it's a combination of 3 bones. Your hip bones, or your coxal bone, is a combination of 3 fused bones. We have the ilium bone, which is, we talked about the iliac crest a little bit ago when we were talking about some terminology. That's your kind of love handle bone area. You have your pubis bone, which is near your pubic area, genital area, and the front part of your hips. And then we have your ischium bone. Those are the bones you sit on when you're sitting on like a hard surface or sitting on the floor. And when you combine the 2 os coxae, so you have an os coxae on the left and an os coxae on the right, so they are connected in the front by that pubis area, but when you connect them with the sacrum and coccyx bones, what you get is this whole unit, and what we call that is the pelvic girdle. So remember, the shoulder girdle or the pectoral girdle was just 2 bones. It was the scapula and the clavicle that help to move your shoulder. The pelvic girdle, a little bit more complicated. We actually have a total of 8 bones. So we have ilium, ischium, pubis on the left and the right, and then we have sacrum and coccyx. So let's move on to the next picture, and I'll show you a more defined illustration of these 3 coxal bones. Well, I lied. Pictures on the next slide, coming up shortly. So once again, the os coxae, or the coxal bone, is made up of 3 bones all fused together, and you can see their names right here. And as I mentioned, the ilium is the uppermost. This is kind of your love handle area. Ischium is the lowermost. So these are the bones that you sit on, at least on a hard surface. If you're sitting on like a couch or a pillow, you could be sitting more on like your sacrum or coccyx area. And then the pubis bone is just on the anterior front part. So there are going to be 2 important markings that you need to know with the os coxae. Number 1 is the actual hip socket. We've talked about this before. It's called the acetabulum. This is where that head of the femur is going to fit in to actually make your hip joint. So what the acetabulum is a combination of all 3 of these bones fused together. And then we have the pubic symphysis, or as you can see in your notes, it's also known as the symphysis pubis. You'll see it both ways. But that's basically an area where in the front part of the pelvis, the 2 pubic bones connect to one another. And this area can be stressed, especially during the childbirthing process and the female. So we need a really, really strong cartilage in this area. So this is one of those unique locations of the body where we find a lot of fibrocartilage. Remember, we have them inside of the meniscus of your knee. We also have it in the intervertebral discs between your spine. And then here we have it in the pubic symphysis, holding your 2 pubis bones together. So now let's go on to the next slide. I'll show you a picture of these 3 bones. There we go. Okay, so getting our orientation right. Both pictures are a picture of a right hip. So what we did was just pretend we had surgery and we're replacing your hip, and we removed the entire right hip area. And all we're doing is, on this picture on the left, we're looking at the lateral view. So you're looking at kind of from this angle. And then the picture on the right, you're looking at a medial view. So you're looking at the same hip, but you're looking at it from that perspective. So they're just going to look a little different. First, I want to show you the acetabulum. The acetabulum, once again, is the hip socket. So you can only see that from the lateral side because that's where the femur is going to be located. So that's this big fossa, if you will, indentation there. Now, once again, as you notice, it is a fusion of all 3 bones. We have the ilium. I'll put IL for ilium here. We have the ischium in orange. And then we have the pubis in purple. And if you look at this hip socket area that I'll circle, what you'll notice is you get all 3 colors. You get a little of the tan ilium, you get the orange and the purple. All 3 bones make up this hip socket called the acetabulum. So what the next thing is going to be the pubic symphysis. I'll show you that hopefully on another picture, but the pubic symphysis is just a pad of fibrocartilage where the 2 pubic bones are held together. So here is the medial aspect of this pubic bone, and there's the medial aspect of this pubic bone. So holding these 2 things together is going to be this really, really strong, tough, collagenous fibrocartilage. So here we go, putting the whole pelvic girdle together. So now you have the os coxae on the right, os coxae on the left, because we're looking at an anterior to posterior view. And now, since we have the sacrum and the coccyx, this is what we call the pelvic girdle. It's all connected. So to highlight the pubic symphysis, it's this area right here where the 2 pubis bones are connected. So it's a pad of very, very strong fibrocartilage. And then once again, in purple this time, you can see the acetabulum. These are the sockets where the femur heads are actually going to fit into to make your hip joint. Speaking of femurs, let's start working our way distally down the lower extremity. Femurs are the longest bones in the human body. They're also the largest bones in the human body. They're also the strongest bones in the human body. Certain parts of the femur are actually said to be stronger than steel itself regarding how much torsion and force they can handle. Very, very, very strong bones, and you have some very, very, very strong muscles in this area as well, the quads and the hamstrings that that are moving in this area. So very, very strong part of the human body. Few bone markings we want to point out. The head of the femur, as I've been mentioning, that's what actually fits inside of that acetabulum. So very similar to the head of the humerus. What I want to point out is, let's do the head in red. Once again, we're looking at an anterior view on this picture. We're looking at a posterior side on this picture. So the heads are medial. So therefore, anything on this side of the bone is going to be a medial blank, and then anything on this side of the bone, when purple, is going to be a lateral blank. So that'll help us with our orientation. Once again, getting inside the lab if you can, or playing with a digital atlas will greatly help you see the 3D structures of these bones. So next we have the neck. The neck is just what's connected to the head, just like in our body. So it'd be this area right here. Very commonly fractured in the elderly as our bones start thinning and getting weaker. And then we have two very, very big processes, very big bumps that help us with muscle attachment, and they are called trochanters. And we have a very large bump called a greater trochanter and a not so large bump called a lesser trochanter. So you can see the greater trochanter on the anterior view right here in blue, big bump. You can also see it here on the posterior view. And then you can also make out the lesser trochanter right there, this bump. So once again, these bumps are for muscle attachment, very strong muscles. And then as we work our way distal towards the knee joint, we have similar structures that we've seen before. We have condyles and epicondyles. So condyles are the smooth surfaces that usually fit into some type of fossa, right? Make a joint. And then epicondyles are generally proximal to those, and those are used for muscle attachment. So a little harder to see in the femur, though. The humerus is a lot easier to make out the epicondyles, but we'll do our best. For the medial epicondyles, it's just these big protrusions right here at the very edge of the femur. For the lateral epicondyles, same thing. They're just going to be protrusions on the lateral aspect right there. And then we have the condyles, and the medial condyle is obviously going to be on the medial side. So we'll do that in, let's just keep it consistent, orange. That's going to be the medial. And then the lateral condyles will be on the lateral side. And as you can see, the condyles are joining with that bone right below us, our shin bone, also known as the tibia. But before we get to the tibia, let's talk about our kneecap real quick. This is known as the patella bone. You're actually born without this bone. In that area, generally, it's just cartilage. And then as we age, start crawling, moving around, that cartilage does ossify and it becomes a bone known as the patella bone. Next, we have the two bones of our lower leg, the tibia and the fibula. A lot of students get those mixed up, tibia and fibula. So when we think about shin bone, tibia is typically the big shin bone. It's really easy to feel. Just feel the front of your lower leg. You're feeling the anterior crest or anterior border of the tibia. The key thing to always understand, to make sure you don't get this confused in lab, is the tibia is always the more medial one. If you remember that, you're good. No test question is going to trip you up. And since the tibia is more medial, therefore the fibula by default has to be more lateral. So what we're looking at in this picture, same thing. We have an anterior view on the left. We have a posterior view of the two bones on the right. So this bigger bone, that's medial, is the tibia bone. And then the really, really long, skinny bone on the lateral side, that is the fibula. So let's move on to the next slides and talk about some bone markings for these two bones. First, let's begin with tibia. Now, what I've been telling you since the beginning of this chapter is, generally speaking, and I say the word generally and I say the word typically a lot, mainly because there are weird exceptions throughout the human body. So it's not always 100% this is 2 + 2 = 4. Sometimes 2 + 2 = 4.5. And this is one of those weird situations where I've been telling you for the longest time, a condyle is a smooth bump or a rounded surface of a bone that fits inside of a groove called a fossa, right? And we've seen that in multiple examples. We've seen that with the mandibular condyle and the mandibular fossa. We saw that with the occipital condyles and that kind of groove in that first cervical vertebra, the atlas bone. This is one of those weird exceptions. So on a couple slides ago, we just talked about the condyles of the femur, the medial and lateral condyles. And what you would think is it fits inside of a fossa on the tibia, and that's not really the case. We have two condyles in the tibia as well, or on the tibia as well. We have a medial condyle, which is this area right here in purple, and then we have a lateral condyle in this area in green. Now we do have this top portion called the tibial plateau, but notice it's a plateau, it's flat. So there's not really that big of an indentation, and that's what gives our knee it gives us freedom to run and to put a lot of weight on our knee, but it also gives us some liability and susceptibility to injury. Because if that femur bone, let me draw it for us, if that femur bone with those big old condyles slips off of that tibia, you are tearing every single ligament that you have, and you possibly have a dislocated knee, which is going to be absurdly painful. So one of those weird exceptions here, the tibias on the femur articulate with the condyles of the femur, if that's what I was trying to say, the condyles of the femur articulate with the condyles of the tibia. Weird exception. The next important bone marking that you need to know is something called the tibial tuberosity. We've actually highlighted this before. We're learning about T words, right? Trochanters, tubercles, tuberosities. They're all big T words, and all they are just processes for muscle attachment. I talked about soccer players having a really large tibial tuberosity because those muscles, tendons are just pulling on that bone, making that bump really big. And it's located right there. And then if you go all the way down to the bottom or the distal end, what we have is the ankle area, the ankle joint. Now, what I want you to do is, as you're listening to this video, feel your ankle. Feel both sides of your ankle. And what you'll feel is you'll feel on the medial side you have this ball-like structure, and on the lateral side you have this ball-like structure. On the medial side, the medial ball-like structure, what that is a big thing sticking out of your tibia bone. And that is called the medial malleolus. Now, it's only on the medial side because it's only found on the tibia. So that bone on that bump, or that circular looking thing on the medial side of your ankle, that is your tibia. And specifically, it's the medial malleolus of the tibia. On the lateral side, it's a completely different bone. That is your fibula, and what we're going to call that is the lateral malleolus. So those two bumps are thanks to two different bones, tibia on the medial side, fibula on the lateral side. So you only have a medial malleolus on the tibia. When looking at the fibula, as I just mentioned, you can only feel a lateral malleolus. There's no such thing as a medial malleolus of a fibula. It's the lateral bone, so therefore it only has a lateral malleolus. And then one other structure we want to point out is the head of the fibula. That's the proximal part right here that actually articulates with that lateral aspect of the tibia. Okay, so we've talked about carpals before. Carpals are the bones of your wrist. and therefore tarsals are the bones of your ankle region. So we have a total of 7 tarsals. We're going to highlight 2 of them that we absolutely want you to know. But similar to the wrist, right? We said the wrist has 8 bones, and just know that those are called carpals. Same thing here. Your tarsals have 7 bones, and we don't need you to know all 7, but we do need you to know the 2. And they're not more important than the other ones, but they're 2 very easily recognizable bones. How about that? So those 2 recognizable bones are the calcaneus and the talus bone. So the calcaneus is also known as your heel bone. That's the kind of gold yellowish bone in the picture. And the talus bone is what actually your tibia and fibula articulate with, this purple bone. So the lateral malleolus of the fibula and the medial malleolus of the tibia actually anchor or touch this talus bone. So what we have is we have a medial malleolus and a lateral malleolus, and then we have a bone anchoring them. That is your ankle. So it's the talus and then the ends of the tibia and fibula that makes your ankle actually be able to move. Similar to the hand. In the hand, we called them metacarpals, right? Instead, here we're going to call them metatarsals. These are the 5 bones that make up the long portion or the arch of your foot, or just really the top of your foot. And we have 5 of them because we have 5 toes, hopefully on each foot, right? And exactly similar to the fingers, we're going to call these toes phalanges. And it's the exact same anatomy. So here on this side, we're looking at the big toe. So all we have is we have a proximal phalange and a distal phalange, and that's it. But all the other ones have 3. And I'll try to highlight that for you. Let's look at the second toe. You got 1, and then you have 2. I'll just put a dot there so you can see them, and then the third one. 1, 2, 3, 1, 2, 3. Pinky toe really small, but there are still 3 bones. So we have a proximal bone. Remember, the middle one's either called the middle bone or the intermediate bone, and then the distal bone, and more specifically phalange. So proximal phalange, middle or intermediate phalange, distal phalange. Okay, that is it. You have now covered all 206 bones of the human skeleton. These last 4 slides, what I want to do is just go over some differences between the hands and feet, and then we'll talk about the male-female pelvis specifically, and then we will wrap up this skeletal chapter. So, hands and feet, as you just saw, I just sped right through the tarsals, metatarsals, and phalanges. And the reason why is because anatomically, they're pretty much the exact same thing, right? We have 8 carpals and 7 tarsals. Okay, a little difference there. But regardless, we have 5 metacarpals in the hand, 5 metacarpals in the feet. And we should have a total of 14 phalanges in each hand and 14 phalanges in each foot. Right? And the reason why it's not 15 is because that big toe or that thumb only has 2. So anatomy-wise or structurally speaking, it's the exact same thing. From a functional standpoint, though, we want you to know that your hands and feet are not the same, right? Your hands, major function of your hands is a manipulation of things such as manipulating a pen or typing on a keyboard or a cell phone. Other things, grasping and holding on to things, carrying things. And your thumb is very opposable. And what that means is you can move and touch the tips of your fingers to your thumb. And it's because the joint that joins your wrist and your metacarpal of your thumb, it's very, very different than any other joint in the entire human body. And we're going to cover that next chapter. But you can't do that in your feet. You can't touch the tips of your pinky toe to your big toe. You can't, your toes don't move that way, right? So functionally, they're very, very different. The main purpose of your feet is to be very, very strong for support, right? We're constantly walking on them, standing on them, running on them, going up and down stairs on them. So very similar to the spine. Remember, we had curves in our spine. we had those convex and concave, or those kyphotic and lordotic curves in our spine to kind of dissipate the weight, or at least spread out the weight, in other words. Same thing in the foot. We're going to have arches in your feet so we can kind of spread out those forces so we don't have arthritis and damage to our feet. So let's go on to the next slide and I'll show you what those arches look like. So the arches are simply just made up of really strong tendons and ligaments on the bottom of your foot. And once again, they provide support. So we can stand. If I weigh 200 pounds, I can stand on both legs and put pretty much all 200 pounds on my knees and on my feet, right? And hopefully I'm not in pain by doing that. So the three arches that you need to know, and this is an awesome illustration from Wikipedia right here showing you these three arches. You have a medial arch. I'll do this in black. You can see this triangle. So there's a medial arch aspect on the medial side of your foot. You can see this big toe, medial side. And then on the opposite side, on the lateral aspect, you also have a lateral arch. Generally not as prominent as the medial arch, but still, it's still there. This will be on the lateral side, pinky toe side. And then we have a transverse arch going across the foot. And the combination of these three arches give your foot enough support to support the rest of your body weight. So you can walk, run, jog, do all the things you like to do, hopefully without having compromise to your foot structure. Yeah. The last topic that we need to cover for this chapter is just some differences between the male and female skeleton. First difference is, generally speaking, guys are a little larger than females. If you take the average male, there's 3.5 billion of them on Earth. If you take the average male versus the average female, the other 3.5 billion of people on Earth, generally speaking, guys are a little larger than girls. Now, one of the main reasons is because of, we talked a little bit about this in Chapter 6 with the hormone change. Once females hit menopause in older age, they have a harder time maintaining strong bone density. So they have to possibly work a little harder in the gym to make sure their bones are strong. So that's one difference. The second difference I want to point out are the differences in the male pelvis versus the female pelvis. So if you take a look at the shape, and I'll have a picture on the next slide, male pelvises are generally a lot more narrower, where female pelvises are more spread out. And the reason why is, if you take a look at this bottom bullet point, it's because females have, well, I'll let you choose either the blessing or the curse of having children. So if they are having a natural birth and they're pushing a baby out of that area, out of their hips, their pelvic area, they need a little bit more space, right? And then they have to push it through the cervix and the vaginal canal. So it's a little more spread out in that area, but also the angle of the pubic arch, which is basically this imaginary angle measuring underneath the two pubis bones where they meet. So let's move on to the next picture and I'll show you the difference. With the pubic arch, the females are going to have a much larger angle. So what we're looking at in this picture is the female pelvis on the left and the male pelvis on the right. And what you'll notice is the female pelvis just has a little bit more room. Although it's more shallow, it's more spread out from lateral to medial. So there's more room in this circular area to pass a child through. Versus the male pelvis, yes, it's deep, but it's very narrow from a lateral to medial perspective. And then the last difference was that pubic angle. If you take a look at the pubis area, so here we have our pubic symphysis holding the two pubis bones together. In males, when you draw this angle that connect the underneath or the underside to the pubic bones, you get this kind of smaller angle, this acute angle, where in females, it's just a little more spread out, a little wider. And that just shows you that the hips are indeed wider, if you don't believe me, in the female pelvis. So those are the big differences. Make sure that you study this material. You should know all 206 bones in the body for lecture and lab. You should also know all of the specific bone markings that we talked about today for lecture and lab. And make sure you let your instructor know if you have any questions, and I will see you next time for the joints chapter.